Hello, and welcome to the lecture on complicated grief. So to give us a sense of what complicated grief is about, let's read this vignette and talk about what are some of the features that make it a sign of complicated grief. So after Stephanie's 13-year-old son, Eric, died of Ewing's sarcoma, she was lost in a sea of grief. Her days were long, unstructured, and monotonous. She barely left her New Jersey home. When she did leave, she planned her routes carefully to avoid driving past the hospital just a few miles away where Eric had been treated during the 16-month of his illness, or the fields where he played baseball. Grocery shopping was a minefield because it was painful to contemplate buying Eric's favorite foods without him. To enjoy anything when he could not felt wrong. And Stephanie never thought she would be able to return to the temple where she had celebrated his bar mitzvah and where his funeral was held. Looking back, one of the things she said is that she thought if she stopped grieving, her memories of Eric would fade and she'd lose her connection to her son forever. The passage of time often seems the only remedy for grief, but time did not help Stephanie. In the years following Eric's death, she says she felt consumed by grief. 4 years after Eric died, it felt to her as if Eric had died just the day before. So we're going to be talking more about the features of complicated grief, but persistence is one, right? And so it's lasted not just a year, but it's persistent for, many years, 4 years it looks like here. It also appears to be the level of symptom severity. It's intense emotional pain that really hasn't changed over time. She's doing a lot of avoidance of reminders, which makes sense maybe in the first months or year, but is a little bit of a red flag when we're at 4 years out. And she seems to have really lost normal life function. So when you think back to that dual process model, right, of being life-focused and loss-focused, she's really stuck in being loss-focused and not able to be as much life-focused. Okay, so here's what we'll be covering in this lecture: normal versus complicated grief, diagnostic criteria for complicated grief, factors that increase our risks of complicated grief, the overlaps between complicated grief, depression, and post-traumatic stress disorder, and how they're similar and how they're different, how we treat complicated grief, and one of my favorite topics, how differential susceptibility relates to complicated grief. Okay, so starting with normal versus complicated grief. So first, let me just ask what you think. Could complicated grief happen to anyone depending upon the circumstances? The point I want to make with this is yes. We could have amazing resources and social support and coping skills and knowledge, but given the right circumstances, any one of us, including me, could experience complicated grief. So just to give us a sense, additional information on how complicated grief might emerge, you might watch this clip about the loss of Rebecca's father and Ted's father in the show Ted Lasso. And what I'll just note here is that Rebecca's, really unable to grieve her dad because she's still so angry that he had an affair. And Ted also really pushed away his grief for his dad because he was so angry at his dad for kind of giving up and dying by suicide. Okay, so we typically use these words like normal versus complicated grief, but normal implies that complicated grief is abnormal, and that doesn't always sit so well. So it could be typical or ordinary grief might be better terms. So generally, if we are experiencing normal, typical, or ordinary grief, basic grief support is going to help us. A grief group, a lot of the education that you learned about in the grief processes lecture, information that we cover in the helping skills lecture can all be appropriate for normal grief. But once we get into complicated grief, then we often need a little bit more. So as helping professionals, we're often having to know when is it just kind of basic grief education and when do we need to move forward with more in-depth care. So we talked about already the definition of complicated grief in the grief processes lecture, and again we're going to be getting more into diagnostic criteria, but a basic definition is that it's overwhelming and persistent ways leading to unhelpful behavior or unproductive ways of living with the loss. And it's estimated that about 10% of us, when we're grieving, will end up experiencing complicated grief. Okay, so what are some forms that complicated grief can take? It can vary, right? But it could be just chronic, like we saw with Stephanie, that idea that if I hold on to the pain, I can hold on to them, right? And so that's kind of the place that I'm stuck in, is just being very loss focused. And things that seem to make sense in the beginning, like really, you know, holding on to their belongings, keeping their room the same, you know, start to make not so much sense if they're persisting for years. Chronic or complicated grief can also just be inhibited grief. And this could be maybe because the relationship with the person was complicated. Maybe they were abusive. Maybe there's unresolved issues. Maybe we don't think they're worthy of grieving, like in the Ted Lasso example, Rebecca not wanting to grieve her dad because she's so angry about his infidelity. Or maybe there's ambiguity around the cause of death. Maybe there's an ongoing investigation, and so there's just too much going on. You know, delayed grief kind of turns into inhibited grief in some way. And then lastly, it can be distorted or masked. So this is basically grief that's been inhibited and then comes out in some other ways. And so in the Ted Lasso example, this is Ted's grief about his dad really coming out as triggered by his current divorce as panic attacks, right? And it's unclear why he's having these panic attacks, but it's probably due to unresolved grief about his dad that's been coming out as these panic attacks in this way. It can also come out as extreme anger or conflicts and fighting with others, or persistent physical symptoms, aches, pains, sleep disturbances, other behaviors. My mom, as you know, was a grief counselor for many years, and she had a client who came in with his wife presenting with sexual desire differences, in which the man wanted to have sex for many hours every day, and his wife was getting a little weary. You know, they were in their 50s. And it turns out that he was a Vietnam vet who had also had a history of childhood trauma. And so he had a lot of unresolved grief that was coming out in this masked or distorted way as a need for sexual connection, basically because during sex, during that intimacy, was the one time that he felt safe, right? And didn't have these kind of intrusive, you know, fears, anxieties, you know, symptoms related to complicated grief and trauma. Catherine Shear is the leading expert on complicated grief. We'll be getting to her treatment model later in this lecture, and so I really encourage you to watch the first 7 minutes of this talk with her, where she distinguishes how complicated grief is different from ordinary or normal grief, how it's similar or different from depression, and why it can happen to us. So Catherine Shear's inventory of complicated grief includes items like in the ways that grief is persistent in terms of months or years, that sense of disbelief or feeling dazed, the anger or the bitterness, the intense emotion or yearning, the preoccupied thinking, the rumination, the distressed or intrusive thoughts, the avoidance behaviors like we saw in the vignette, you know, not going to things that would remind you of the deceased, and persistent hallucinations. Again, these are all things that we would consider normal or typical kind of in the first months or year following a significant loss, but we might start to see signs of complicated grief if they're persistent. So some additional indicators could be persistently over-idealizing. So it can sound great when someone's like, oh, they were the best mom ever, couldn't have asked for anything better. Persistently just only talking about the positives over months and years and not acknowledging that they were also a flawed person too, and they had shortcomings and maybe things weren't perfect. That ritualistic behavior that interferes with well-being. So in the vignette we saw in the beginning the example of like you're constantly driving out of your way or not doing things that actually, like attending your temple, which would actually be helpful for your well-being. When you can't talk at all about it, like you can't discuss it, that's also a red flag. I mean, obviously there's some people that you don't want to talk to about because of privacy reasons, but if you just can't talk to anybody, that's a concern. And then of course, if it's coming out in terms of substance abuse or other self-destructive impulses. Okay, so here are some things that would not be considered indicators of complicated grief. So having a re-grief reaction, right? We've talked about that anytime we experience a new loss, it's normal to re-grieve losses from the past. Experiencing intense guilt and anger, that can be a normal experience with grief. Feeling as though a part of oneself has died along with the loved one. Again, in the short term, and if this, it's normal for this feeling to be intense over the long term, it's likely to lessen. Maintaining parts of the environment in a way to remember the deceased. So this can vary, and it can certainly move into complicated grief or being an indicator of complicated grief. So if you have a little place in your home where you kind of honor their memories or collect items that represent them, and maybe for a short-term time you maintain their room, but if over the long term you maintain the room and nothing can be changed and everything's kind of really rigid and challenging about that, that might be a sign of complicated grief. And then taking action so that others will not forget the deceased, so holding a golf tournament, every year, or some sort of fundraiser, or a 5K, or things like that to honor your loved one aren't signs of complicated grief. So is this complicated grief? After Naomi's son died, she created a special wall in her home to display memorabilia that she freely shares with guests. And I would say no, this isn't complicated grief. Now again, if Naomi had kind of mummified, the term is often used, her son's room for years, then that might be more of a potential indicator of complicated grief. How does complicated grief correlate with health issues? Shear's research on this says that we can see neuropsychological changes. So if you put people who are experiencing complicated grief in an fMRI machine, they'll show some brain differences, specifically in their reward system in response to reminders of the deceased, like photographs, also in terms of their emotion regulation and their autobiographical memory. And I don't know the details on these differences, but I do know that these are kind of brain regions that seem to show some differences. Complicated grief is also correlated with a higher risk of substance abuse, suicidal thinking, sleep disturbances, which of course when we think about it, that can start to get tied up with suicidal thinking, right? And then could also, because sleep disturbances can lead, sleep problems are actually a risk factor for suicidality. So those could kind of be correlated. And then of course, sleep disturbances can also put you more at risk for impaired immune function, which we learned is really normal within the first year following a significant loss, but persisting past that might be an indicator or might be more associated with complicated grief. Okay, so now we're going to transition into some international and national diagnostic criteria for complicated grief or prolonged grief disorder. So as we get into assessing and diagnosing complicated grief or prolonged grief disorder, what you're going to notice is that there's these three criteria. So what's the degree or severity of the grief symptoms? How long have they been going on, the time? And function is how much are they disrupting our daily activities. And you might imagine that these three criteria are very similar for lots of mental health issues, right? How severe is our depression or OCD or anxiety or ADHD? How long has it been happening, and how disruptive is it? So before we get into the specific diagnostic criteria, let's just talk about some of the pros and cons of diagnosing complicated grief or prolonged grief disorder. So this has been in the works for decades. It's been very controversial whether or not to call grief in any form a disorder. But some of the pros of that, having watched this debate, are that it allows, once you have a label or a diagnosis, then you can get insurance reimbursement. It also might help us guide treatment decisions. Like we know that if you have just normal or typical grief, this treatment works. But if you have complicated grief that we really needed to pursue more specialized treatment, it has the potential to allow for funding for clinical trials for medication or other interventions. And it just draws more attention to this phenomenon of complicated grief. The cons are, of course, that it does pathologize grief, something that could happen that's normal, and maybe doesn't need to have a diagnosis, but instead just we need to learn to live with and incorporate. And it also could lead to unnecessary medication. We tend to medicalize mental illness when sometimes therapies might be just as effective or more effective without the side effects. So the International Classification of Diseases is put out by the World Health Organization, and it's a way to standardize diagnoses around the world, so that if you had a diagnosis in one country, it would transfer with your medical records to another country. And so prolonged grief disorder is a fairly recent addition. It hadn't been in there before. And so here's the criteria, and this is going to sound familiar to the slide that we just looked at in terms of degree, time, and function. So that first one, persistent and pervasive longing and or preoccupation. So again, that's that time function. Then intense emotional pain, so that's the degree function. And then if we skip down to number 4, significant impairment in a few different areas, that's that functioning component. And then they added this third one, which is the cultural context, essentially, because we know that some cultures, especially more collectivist cultures that with an emphasis on a continuing bond, have long emphasized, grieving and honoring the person over many years. Some cultures, widows wear black, for the rest of their lives. And so we want to be taking into account the cultural context when we're thinking about whether or not this is unusual. Prolonged grief disorder was also recently added to the American Psychiatric Association Diagnostic and Statistical Manual. And again, this was after many years of debate. We're going to see some similarities to the criteria that we saw with the World Health Organization. The DSM indicates at least 12 months, so it puts that specific time period on it. Again, that intense longing or preoccupation with the person who died. And then 3 or more disruptive symptoms. Perhaps not having a sense of who you are anymore, this profound sense of disbelief, taking action to avoid reminders of the deceased, again, intense emotional pain, difficulty pursuing other daily tasks, a sense of emotional numbness or meaninglessness or intense loneliness. Again, grieving individuals, we can relate to many of these. But what's going to distinguish normal grief from prolonged grief is that, again, this is going to be persisting past 12 months, and then it's going to be clinically significant. It's going to be disrupting our ability to work, to go to school, our social lives, in other areas, or perform daily tasks. And then again, the DSM adds in this exceeds cultural norms as well, similar to the World Health Organization. So just to help us get clear on the difference between complicated grief and normal grief, or prolonged grief or complicated grief and normal or typical grief. Okay, so here's a couple of vignettes. The first one, a 59-year-old man has been widowed for 3 months after 35 years of partnership and marriage. His husband died unexpectedly of a heart attack. He complains of concentration problems at work, difficulty sleeping, and finds himself drinking in excess of a 6-pack of beer on weekends, which is unusual for him. He's crying daily and calls his daughter 5 to 6 times a week. Occasionally, he believes that he hears his husband calling to him from some distant place in the house. He admits to some anxiety regarding the possibility that he's going crazy. So again, I've got that chart up there reminding you of what you're asking yourself about. So symptom severity, the degree of the symptoms. Yes, he's definitely meeting that. Time. So this just says 3 months. So in this case, he's not meeting the criteria for time by either World Health Organization, which doesn't specify a time, or the DSM, because we wouldn't expect 3 months isn't very long, especially for a sudden death that you weren't anticipating. And then function, that sounds like it is disrupting his function, right? He can't concentrate at work. He's having difficulty sleeping. So again, he's meeting some of the criteria, but because it has only been 3 months, he does not meet the criteria for complicated or prolonged grief. Okay, second vignette. A 68-year-old woman seeks care from her primary physician because of trouble sleeping 2 years after the death of her husband. She reveals that she's sleeping on a couch in her living room because she doesn't want to sleep in the bed that she shared with him. She isn't eating regular meals because that cooking makes her miss him too much, and she still has meals that she cooked for him that are in her freezer that she can't bear to throw out. She often talks about how unfair it was for her husband to die. She's alternately angry with the medical staff who cared for him and angry at herself for not recognizing his illness earlier. She finds it too painful to do things that she and her husband used to do together, and she thinks about him constantly and often wishes she could die to be with him. Okay, again, this patient's meeting the criteria for degree of severity, symptom severity, and time, because we're looking at 2 years, and also function. She's not kind of performing normal daily tasks around sleeping and eating and doing enjoyable activities. So this would be a case of yes, complicated or prolonged grief. So now let's get into some factors that could increase our risk of complicated grief. Okay, this slide should look familiar to you. We've gone over this model before, kind of factors influencing the grief process. And so I'm going to highlight on the upcoming slides some factors associated with each of these areas that increase our risk of complicated grief. So starting with characteristics of either the bereaved or family members. So again, as we heard from Catherine Shear, older women are more likely to report complicated grief. And again, that's probably not surprising because females in general report higher rates of anxiety or depression. Again, I want us to caution us on thinking that necessarily females experience more anxiety, depression, or complicated grief. They might, but they also just might be more likely to report it, and it might look more recognizable as grief, and not instead for many males it might show up as hostility, irritability, aggression, substance use, kind of stoicism, and might not be as easily detectable. If we have a prior history of anxiety or depression, we're more at risk, and we're going to get more into the similarities and differences between depression and complicated grief. Pileup of stressors, that makes sense, right? Could put us at risk for complicated grief. If we have previous unresolved loss or trauma, because as we've talked about, we re-grieve old things anytime we experience a new loss, and so that makes sense that could be a complicating factor. If our family hasn't been as strong in terms of communication, flexibility, our ability to adapt to things like a loss, or our cohesiveness, our ability to come together and support one another around loss, then that puts us at risk. And then what about gene-environment interactions and differential susceptibility, if you've learned about that previously? We're going to be talking about this more at the end of the PowerPoint. Basically, there's some evidence that suggests that orchids who are more genetically sensitive to their environment, for better or for worse, are thus more responsive to the presence or absence of life stress and or support. So with a really supportive environment when they're grieving, they might be doing better, but if their environment isn't so supportive, then they might be struggling more. All right, so what about characteristics of the person who died? So if this was an off-time death, if they were too young, it was unexpected, right? That's more challenging, puts us more at risk for complicated grief. If it was these relationships, specifically having the death of a child or the death of a partner, can put us more at risk. If we had unresolved relationship issues, so we had really hoped for more out of that relationship and they weren't really there for us like we wanted, or we had conflict that we hadn't addressed, that can create challenges for us. I remember talking with a student whose dad had been struggling with mental health issues and depression for many years, had been institutionalized for some of that time, and then had died by suicide. And so there was a lot of just a sense that she had lost him for many years before he actually died, and that was all unresolved. And of course, if the deceased person was abusive, then that increases our risk of complicated grief. We're going to be spending more time on sudden death at the end of the semester, but again, if deaths are sudden, violent, traumatic, like suicide, homicide, accidents, if they're it makes things challenging. If they're preventable, boy, that's really tough because it's like we could have done something to stop it. And if they're ambiguous in some way. So I worked with a woman whose son died, and it was unclear initially if it was suicide or if it was homicide, and then once they thought it was homicide, it was an unsolved murder, they've never figured out who or why. And so that sort of ambiguity leads to just a really long and challenging complicated grief process. And then with these types of death often comes the societal factor of stigma, right? And we're going to be getting more into that as well when we talk about sudden death, but victims are more blameworthy. Grievers are seen less, as we're less likely to give them condolences. We might hold them somewhat accountable too. So now we're going to get into how complicated grief, depression, and post-traumatic stress disorder can be similar, and also how they can be different. Okay, so in looking for research on this, there's not a lot, but there was a small study of about 200 people who were seeking treatment for complicated grief, and they were assessed to see if they also met the criteria for major depressive disorder, or MDD, and post-traumatic stress disorder, or PTSD. And so what you can see there is that about a third were complicated grief only, and then about a little over half, because there was overlapping, right, had complicated grief and met the criteria for major depressive disorder. About half, again, had met the criteria for complicated grief and PTSD, and then another third met the criteria for all three. So this goes, helps us understand that it can be separate, but it can also be co-occurring. Okay, so here's the criteria for major depression, just to a major depressive episode. So basically, you have to have shown these symptoms for a minimum of 2 weeks. And so that's depressed mood most of the day, nearly all day, every day. And so most of us can relate to feelings of depression, but it's rare that we would feel that way pretty much all day, every day for a minimum of 2 weeks. That includes things like loss of interest in pleasure, some physical symptoms like weight loss, gain, appetite loss or gain, struggling to sleep, being more agitated or lack of movement, feeling this profound sense of worthlessness or excessive guilt, struggling to concentrate, and thinking about suicide. So when we look at this, it's like, wow, for someone who's grieving, especially an intense loss, maybe a sudden death or someone too young or someone close to them, we could imagine that they would meet all of these criteria. So how do we know when it's depression and when it's grief? So here's some distinctions. Grief tends to be more trigger related. You wake up and you are reminded that they're gone and you feel sad, but then you get going and you do okay, and then something else happens and it reminds you and you feel sad again. So it can be more variable, essentially, whereas depression tends to be more static, and even. And grief, although it could be associated with self-loathing and worthlessness, especially if we feel like we're somehow to blame for the death, that's generally not a part. It's more of a part of depression than it is a part of grief. But again, it can co-occur, and it can happen in a couple of ways. So first, we could have unresolved complicated grief that really starts to also meet the criteria for major depression, or we could have had major depression before this loss even happened, or there could be other things going on that are leading us to experience depression. So you might just pause for a minute and ask yourself, just to help consolidate what you just heard. If someone said, I don't know, am I grieving or am I depressed, or is it both? What is it? What would you say to them? So the overlap between PTSD and grief, complicated grief, is less controversial because we could imagine sometimes we could experience a very traumatic event that would lead to both. So you can see there again, it can co-occur about 30 to 50% of the time. Here's the criteria for PTSD, or post-traumatic stress disorder: that you or someone close to you has experienced a traumatic event. It can't be through the media. That is leading you to have these kind of persistent rumination, intrusive thoughts, re-experiencing kind of flashbacks. Also avoidant symptoms, avoiding thinking, avoiding places that might be triggering people, a persistent kind of negative mood or thinking, and just that heightened arousal, that increased hypervigilance, being in tune and expecting danger, being on edge. And this needs to be persisting for at least a month in order to meet the criteria for PTSD. So again, sometimes people are going to have complicated grief, but they're not going to meet these criteria, and sometimes they're going to meet both. So as I mentioned earlier, for normal or typical grief, basic grief support groups, grief counseling works. But if someone has complicated grief, then we need a more specialized, ideally evidence-based protocol. So the complicated grief treatment that was developed by Catherine Shear, who you heard from in the beginning of this PowerPoint, was based on, or has been around for 2 decades. It has some really nice evidence base behind it. There's been randomized clinical trials demonstrating its effectiveness. It consists of 16 weeks or 16 weekly sessions, and it draws on treatment protocols for PTSD, as well as cognitive behavioral therapy. And so it involves things like imagining yourself talking to the person who died. It also involves telling the story of the death and the circumstances around the death. Oftentimes you might even record yourself telling that story and then listen to it every day, kind of this desensitization protocol. And then this process, this stepwise process for beginning to engage in places or situations that you were avoiding. So like that vignette we heard at the beginning of the PowerPoint from Stephanie, where she was avoiding the temple, right? There might be steps to, okay, how are you going to reach out to your rabbi? Could you stop by on a non-temple day and just walk through, and then, so things like that to kind of get you back into things that you've been avoiding. Also, another potential treatment for complicated grief is EMDR, or eye movement desensitization and reprocessing. This is a trauma protocol, so it's not specific to death losses. It could be any types of traumas. And so EMDR also has a nice evidence base behind it. It involves basically revisiting traumatic experiences while being bilaterally stimulated. And so that means either watching someone's hands move back and forth, watch lights, you can close your eyes and listen to sounds beeping in your ears back and forth, or hold buzzers that vibrate in your hands and go back and forth. And the idea is that this bilateral stimulation while revisiting traumatic or difficult experiences allows your brain to break out of its standard neural loops and begin to run some new pathways. If you're interested in it, I'd encourage you to check out the International Association for EMDR, or IMDRIA.org, they list EMDR approved therapists in your area. And my mom was well trained in EMDR, and I spent many years as a client practicing EMDR and found it very useful, even for small traumas. So Susan Delaney was trained by Catherine Shear in her complicated grief protocol, and is a leader in that area in her home country of Ireland. It's a great TED Talk, and she's going to bring up some really nice information. So you can be thinking about what's a myth of grief that she mentions that you want to remember. She has some nice metaphors for grief that you might want to remember, and she also talks about how people can experience complicated grief that might be useful. So let's talk more about one of my favorite topics, differential susceptibility, and how it relates potentially to complicated grief. And a number of years ago, I gave a presentation on this at a national conference for the American Association of Death Education and Counseling. And so this is just some excerpted slides from that. Okay, so you may have learned about this before in other classes, but if you haven't, let me just briefly tell you what the differential susceptibility hypothesis is. It basically says that our genetics influence how susceptible we are to our environment. And so dandelions seem to be just kind of more average or fine, regardless of their experiences. If they're really bad, they still look like a dandelion. If they're really good, they still look like a dandelion. Whereas orchids do poorly in negative environments, as orchids do, right? They require the perfect amount of sunlight and water, but really are glorious if they have really, really good conditions. Another way to depict this is graphically using regression lines. And so the idea that has emerged and is supported by a lot of research studies is that dandelions, again, have kind of just more of an average mid-range response that doesn't change that much based on how negative or positive their environment is. Their outcomes remain about the same and in the middle, whereas orchids really drastically shift based on their environment. If their environment is really poor, then they are doing poorly, and if their environment is really positive, then they're doing really well. So in terms of genetics, these are the most commonly researched differential susceptibility genes, but there is more than this. So there's the 5-HTT-LPR gene, which is associated with serotonin, and manifestations include more intense emotionality, increased risk of anxiety, depression, and it's also associated with secure attachment behaviors. The dopamine genes, one of them being DRD4, is more associated with externalizing behaviors. Things like that might be associated with ADHD, like attention, motivation, and reward, and also substance use. And then the MAO gene affects how our bodies use dopamine, serotonin, and norepinephrine, and it is more associated with aggression. So I've been telling you about differential susceptibility studies related to genes, and you can see that here on this chart under genetics. But there are also differential susceptibilities on epigenetics, because if you've learned about epigenetics, you know that some genes get turned on or turned off. So you may have the gene that makes you more sensitive, but perhaps it's methylated, so it's turned off. There are also research studies on your endophenotype or biomarkers. So these are things that we need to observe, microscopically. And this could be your vagal tone, which is associated with how much you can activate your parasympathetic nervous system or your calming nervous system once you're in distress. Similarly, another term related to that is respiratory sinus arrhythmia. Measure of vagal tone. It could also be how much cortisol you dump under distress and how long it takes your cortisol levels to come back down. So again, people who are more orchid-like are going to have a harder time, have a more intense reaction and have a harder time calming themselves down quickly. And then the last one is phenotype, which is what we can observe with the naked eye, so like your behavior. And so the most common example for differential susceptibility studies is infant and toddler temperament. And so basically babies who are more fussy, who are more irritable, have more negative mood, more easily startled, less predictable. These are babies with a more difficult temperament, and this is a sign of being an orchid, because basically they're more reactive to their environment, they're more easily overstimulated, they have a harder time calming themselves down. So most of the studies that I'm going to be telling you about, I think all of the ones I'm going to be telling you about are genetics, but there are other studies out there. And if you, for example, go into Medline and put in differential susceptibility, you'll actually bring up thousands of studies. So even though we aren't hearing about it too much in our field, it is a really strong emerging area of research. So let's turn to some research on how differential susceptibility is related to adversity and psychological distress. The last time I checked, there wasn't research on differential susceptibility related to grief, so I'm picking concepts that are similar to grief. So this research study was done at UCLA on both students and staff. A small sample, you can see just a little over 100 students or 100 participants ages 15 to 33. And they asked them about life stress during the past 6 months. And then they also measured their level of neuroticism, which is one of the big 5 personality traits, if you've learned about that, and is closely related to anxiety. And so just a little bit more about this was a genetic study on the 5-HTT-LPR serotonin gene. And so with genes, you can have a short version or a long version. You get one allele from each biological parent. And so if you have 2 short versions of that 5-HTT-LPR gene, then you would be considered kind of a true orchid. If you have 2 long versions, you see those LLs there, then you would be considered a dandelion. And if you're heterozygous, you have 1 of each, then you'd be somewhere in the middle. And so what you can see here is that the dandelion dotted line was fairly level, depending upon whether or not they'd had more stressful events in the last 6 months or more positive events in the last 6 months. Their level of neuroticism was sort of in the middle and wasn't that affected. Whereas the true orchids, or the more extreme orchids, I should say, with the 2 short versions of the allele, you can really see a dramatic shift there. If they had more negative life events in the last 6 months, then that they had the highest levels on average of neuroticism. And if they had more positive or less stressful events in the last 6 months, then they had some of the lowest levels of neuroticism. And then people that were heterozygous, had 1 of each, were a little bit in the middle. Okay, this study explores the same gene and levels of family support and depression in adolescent boys. And so what you can see here is the dandelions are the green line, and so they are relatively flat and lower all the way across. So no matter what their levels of family support, which is on the horizontal part of the graph, they have a similar lower level of depression, which is measured on the vertical part of the graph. Orchids, on the other hand, if they have the lowest family support, you can see they had higher rates of depression, whereas if they had high family support, they had even lower rates of depression than the dandelions. Okay, so I bet you're already thinking, what are you? An orchid, a dandelion, or a mix? And I've spent a lot of years thinking about this myself. I do consider myself more of an orchid. I have checked my genes on 23andMe, and I have some of the sensitivity alleles and some not, but I don't know about my epigenetic or methylation patterns. And so the reason why I think of myself as an orchid is I am pretty reactive and sensitive to my environment, easily overwhelmed. But definitely when I think back to my childhood, it was how I was doing was largely dependent upon how my parents were doing. So if my parents were stressed or having conflict or in midlife crisis, my well-being generally matched that and was lower. But if my parents were doing better, so for example, when I was in high school, my mom went back to school to become a marriage and family therapist, and that changed her and our whole family, then I really responded to that, and was doing much better. Whereas my brother, I think, was a little bit more even all the way across. All right, so then what does this mean for treatment? So what this meta-analysis of different therapeutic interventions revealed is that on average, orchids respond more to treatment, which makes sense, right? If dandelions are less responsive to their environment in general, you could put them in this awesome treatment program and they're going to stay in that kind of middle line. Whereas orchids, we can see, are doing well when things are good and they have more support, and doing poorly when they don't. Also, what we found is that interventions that targeted externalizing behaviors like acting out behaviors, risky behaviors, substance use, interventions for those we saw a bigger difference in orchids and dandelions than we did for internalizing like anxiety and depression. So the treatment effects were bigger. We saw a bigger difference. And so what the conclusion is that the dopamine genes, the DRD4, were actually showing more reactivity to intervention than the serotonin, the 5-HTTL-PR genes. Okay, so how does differential susceptibility help our work with people experiencing complicated grief? So how I translate this to complicated grief, even though again there isn't direct research on this, is that we could predict that orchids are more likely to experience complicated grief than people who are dandelions, especially if they had early childhood adversity, and they currently do not have adequate support or intervention. At the same time, orchids are more likely than dandelions to show treatment gains, so they might really benefit from treatment. It's my own personal belief that orchids are the ones keeping therapists in business. So bigger implications for clinical work. If you find yourself in that professional role, I think you can tell people about the difference between orchids and dandelions, and you can normalize whatever one they are. And if they're an orchid, you can say, this is really hard, but the good news is that you're likely to respond well if we can help you increase your social support and your coping skills. And so especially for orchids, you might say things like you're wired to experience the world in a more intense way, for better or for worse, or the bad news is things are going to hit you hard, but the good news is with intervention, you can be amazing.